Hey everyone, welcome to the Ophthalmology Experience, where we discuss everything about ophthalmology, but we focus more on the business side. I'm your host, Guido Piquet. We feature conversations with industry leaders, practice administrators, and physicians about the challenges of running and growing successful practices. Thanks to Boost Patients for helping power and produce the Ophthalmology Experience. Today, we're joined with Dr. Eric Jennings, the medical director of ophthalmology at ModMed, where he worked with cross-functional teams to develop innovative EHR solutions for Eyecare. Dr. Jennings is a cataract, refractive, and cornea surgeon based in Atlanta, Georgia. He's passionate about AI in healthcare and digital health solutions, and his experience as a consultant, beta tester, and super user enables him to integrate cutting edge technology into his practice and help drive advancements in medical innovation. Excited to have you today, Dr. Jennings. Thank you for joining us.
Hi, Guido. Thanks so much for having me, and what a wonderful intro. Thanks so much.
Dr. Jennings, before we get started, I promise I'm not trying to just blow smoke, but I say you're one of the practice administrators' dream surgeons, and here I'll tell you why. Because number one, you're a great doctor from when I hear and what I see. Number two, super easygoing person, easy to talk to, and you seem pretty like a funny guy. I love when you present because you inject humor into what you say, and I think that's a great way to reach people. And then lastly, probably most importantly for a practice administrator, you function without a scribe, and you say that. So so we have something in our practice called the Dr. Jennings watermark. So whenever we have the a technician who calls out at 5:30 and they're going to end up scribing for that day, I tell that the manager tells the doctor, hey, sorry, we don't have the scribe. They called out today, but if Dr. Jennings can do it, so can you. so
Uh,
so thanks
that,
for thanks for setting that bar for us to help us with those conversations.
well, thank you. It's nice to have a namesake in this industry. I'm not sure the wonderful physicians and technicians are going to love that as much. Yeah, very kind of you to say. The humor is important to me. I've had some comments that I should do some stand-up comedy after doing these presentations, but the medical
Yeah.
conferences can get stuffy, so it's nice to do humor. But the functioning without a technician has really just come with necessity, time, and ease of use of our EMR and sort of efficiency, which we'll go into, I'm sure. But these days we have to be efficient, and we have to surround ourselves with a good team.
Okay, well, hopefully we didn't build it up too much for expecting a stand-up comedy routine now. um, so let's talk about. So the reason that I've started doing this is because I want the people who listen to have some kind of value, hopefully, that they get from this when they hear this. And I think the topic we're going to talk about mostly today and some of the solutions that we might discuss are related to current challenges in healthcare, and what are some of those ways that we can solve those challenges. What are those challenges? A lot of them are not new, and people understand that. We're getting paid less for the services that the physicians do. um, our costs to provide those services are going up. It's harder to attract talent in organizations, more so just because there's aging populations, growing patient volumes, and the network of support staff is harder to find. And what did I miss, Dr. Jennings? What are you struggling with currently?
Wow, I mean, you hit a ton of them. Yeah, in terms of creating value, hopefully what we can bring to is because I work cross-function. I'm a physician and I work for big EHR companies, so I see both sides. Right, I see how hard the administrators work. I see how hard the doctors work. I'm one of them, right? So we can kind of provide. None of these challenges maybe are new, but there's a lot of things coming out, and there's ways to work together. So hopefully we can go through some of those for your listeners. But I mean, you hit most of them on the head. We have an aging population, right? The boomers are coming to need a lot of care, and there's a lot of them. And ophthalmology hasn't really increased our residency spots in almost an eternity. So there's going to be a shortage of ophthalmologists and eye surgeons. There's a lot of expectation management. Patients are a lot more educated, and I value that. I want them to be educated, but there's a little bit of a shift in terms of what we need to provide to patients. And as you mentioned, the administrative burdens, right? There's rules, regulation, there's compliance, inefficiencies, staff turnover. It's hard to run a medical business right now with the declining reimbursement. We have to get creative, and that's why it's so important that we work as part of a team: administrators, billers, doctors, scribes, technicians, and industry partners to do this, because you're either going to have to do more cash-based services, you're going to have to see more patients, but that comes at a cost sometimes. So there's a lot of challenges, and I think we can do it. We have a lot of tools that are coming out, but let's say it may not be completely downhill.
Yeah. And you mentioned one of the things I wanted to touch on additionally is administrative burdens, because we talk about the business side here too, is that it seems counterintuitive that payers make it tougher for us to get reimbursed for services we provide, which then creates additional cost for the practice to then comply with those rules. And it creates this downward cycle of more rules, more cost, when if we can just simplify, then we can do it for less, do it cheaper, and hopefully help. We can work together with payers to try to provide care at a better cost. And so, there's a lot of tools. I know that when you working specifically with modernizing medicine and helping to develop those tools, but I think we're going to have to get really creative, right? And how do we solve some of these challenges? And the other thing I'll mention too is just, and I'm just hoping to kind of prompt you to be able to answer this question of not just administrative, but you mentioned the aging population, which means likely, what does that mean for you as a physician, that you'll have to see more patients likely in order to keep the number of patients versus how much it costs to run the practice and keep those numbers in line, right? So when you're staring down the barrel of that, what are some of the things that you think we're going to be able to do to address that?
Yeah, great questions. And that's going to be the hurdle. The population needs care, right? And as a cataract surgeon, cataracts aren't going anywhere. So we have this large flux of patients coming in. They have anything from needing a diabetic exam, they need glasses, they want contacts, they want cataract surgery, they have glaucoma, diabetic retinopathy, right? Some of these folks, haven't been taking such good care of themselves, but we still want to be able to help, and they all need care. And again, there's the ophthalmology numbers. Numbers of us haven't changed much. We've done a good job, I think, of working with our optometry colleagues and splitting up some of the responsibilities. But these people want care, and frankly, they want it now, right? They don't want to wait 3 months or 6 months to see a doctor, but we also want to make sure we're still taking good care of patients. And that's going to be a struggle, right? Some doctors seeing 50, 60, 80 patients a day. At what point does it become too much? And we're leveraging technology, we're leveraging anything to become more efficient such that the doctor can still digest a large amount of information and make educated decisions while still taking care of the patient. But to your point, with payers reimbursing less, because let's face it, cataract surgeons brag about our 10-minute or 8-minute cataract surgery. They say, great, we can pay you less, or we're paying you way too much for this. We say, well, this still took a lot of effort to get here.
Yeah.
And yes, it would be great if they would recognize that sometimes being more efficient could lower the cost of doing business, but they like to have things standardized, so that makes it so we have to do things across the board all the same, which, as we know in medicine, isn't always the case, right? There are some things that are standardized, but there are some things as a doctor, you're like, well, this patient's different or that patient's different. I like that there's a push to make sure we're all doing a good job and all taking care of patients similarly. In medicine, that's the standard of care, right? For a certain type of patient, you want to follow a standard of care. But when it comes to payers, it's challenging to communicate that and to show them some of the cost savings when things don't have to be quite as buttoned up. But hopefully, using some technology and, like you mentioned, creating some efficiencies can help us to tackle this population that really needs care and they don't want to wait a long time. But to help combat physician burnout, we don't want to be seeing 100 patients a day. I would challenge you to ask any doctor who's seeing that volume if they really want to see that number of patients. If I told a doctor you could make the same living and take care of your family the same by seeing half the patients, they would do that all day. but sometimes it's a necessity. And I think we need to find a way to find a nice happy point.
And the expectations from the patients is something that you have to, I guess, put into that formula as well, right? So we talked about the challenges of the physicians and the patients, but there there's an ever growing shift in what patients expect, because you also mentioned that they have access to information. So that can change expectations. There's more information that's being put out by different people, which also can sometimes conflicting, which and new technologies that come out, which can also change expectations. But how do you see, I guess, patients' expectations or shifting expectations kind of impact the formula that we've been talking about as far as providing care?
Great question. I'm one of the docs who likes spending time talking to the patient. I think that contrary to what maybe had been historical, and it still exists to a point, and some patients prefer where you go into the room and say, "You have this condition. Here's your treatment. Bye." Sometimes you schmooze and talk about some things, which is great to get to know the patients, but because, as you mentioned, patients like to know more, and they should, right? It's not really, I'm just going to tell you what you need to do. Well, what if we explain why? I believe it increases compliance. If I tell you why you should be doing these warm compresses and eyelid scrubs for your blepharitis, you're probably more likely to do it versus just do what I say, because it sets
Mhm.
the expectation that this could take a little while for it to work. Plus, with the information age, you can Google anything you want. If you look on TikTok or Instagram, you can find anything you want. You can Google something and find out you may have a horrible disease when really it's nothing to worry about. So we need to educate the patients as to what's going on and give them options. Right? This is a partnership now. The paternalistic era is over, and let's go to cataract surgery. There's so many options out there for what a patient could have. It's a really big decision, and it's one thing for me to tell a patient what they should have. Well, how do I know, right? I can certainly make a recommendation, but I would love the patient to understand what their options are to make an educated decision. And also, patients, again, they don't want to be there the whole day.
Mhm.
They have things to do. Um, they have other things to do with their day. They want to make an appointment. They want to come see their doctor and leave, but they still want that personalized care. So I think it's up to us to balance this, but that makes it tough, right? If you're being asked to see 80 patients in a day, how do you still spend the time to educate patients? And we have other ways. We have other staff members that can help. We have handouts, we have videos. But I still think there's a role of a physician to still educate the patients, because the more they understand, the more they are involved in, frankly, their own healthcare, then they trust you, right? There's a big distrust amongst healthcare sometimes, because if your neighbor's aunt's cousin's neighbor uh,
Mhm.
saw something and you say something to the contrary, well, it would be prudent to explain why, because they say, well, this person did such and such. But I think we at least owe our patients information.
The neighbor rule, I always love that one. So just quick funny story. So my mother-in-law was looking to have cataract surgery, and the first thing she said was, "This person, this person, this person had the procedure, and they didn't have to use glasses afterwards." And I'm like, "Okay, hold on. Let's temper your expectations, because as we all know, everybody's different. Every unique situation is different. You have different options." So I think that when people hear their neighbors, their friends, their family, and you as a practice continue to give great outcomes and expectations, they kind of confuse and don't understand all the things and all the options that they have, and then they might say, well, I want to do what insurance covers, and I don't want to wear glasses because my friend and family had that experience. Right? I'm sure you have the few of those conversations in your practice.
We do all the time, because they're getting the information sometimes firsthand, but sometimes secondhand. So you don't know all of the uh, circumstances that went into that. The contrary example is, I have patients who come in who are understandably nervous. It's eye surgery, right? They're totally nervous, and I get it. It's their first time. It's my 10,000th cataract, but it's their first, and we have to be cognizant of that. So we talk about it. But the reason for them being nervous is, well, my best friend had surgery and went blind. So they're hesitant for surgery. Well, let's dive into that. Well, it turns out the friend also had end-stage glaucoma, and the friend also had a history of high myopia or nearsightedness and had a retinal detachment. So was it the cataract surgery? Well, perhaps, but cataract surgery is so commonly performed that sometimes you only hear about the disasters, right? So you have to take every
Mhm.
patient individually and their individual circumstance. And to your point, people who say, well, my neighbor doesn't have to wear glasses anymore. The interesting phenomenon here is even if they didn't, let's say, get a multifocal lens, some people with a basic monofocal type intraocular lens or IOL can see pretty good far away and they can actually read okay too. It's subjective. So even though one person may say, oh, I can't read anything, another person with the same quality of vision say, oh, I read fine. So those are the
Right.
expectations we have to take into account and educate the patient. You should not be able to read with this style of lens. And if they come out of it saying, "Hey, guess what? I can read," you go, "Well, fantastic." Tell all your friends. But
Yeah. Yeah.
you have to talk about that ahead of time, which takes time um, and patience, right? To help these people make a good decision.
And how do you find the time to be able to have that conversation so that you can set the right expectations? I mean, I've seen many patient satisfaction surveys, and there seems to be very consistent themes. When patients are satisfied, they feel like the doctor heard them, and they had short wait times. I mean, those are the two of the biggest things that patients want. Like they want to get in and out, and they want to have short wait times. And then as you continue to get better as a practice to provide those shorter wait times and to provide those conversations, then that's the new bar. I don't know if you see that in your practice where we'll have, we've done great jobs of reducing patient wait times to where it's pretty close to their appointment time. And so now when patients come in, if it's 5 minutes past their time, they start asking the front desk, hey, are you guys backed up? I'm like, well, we have a big burden to follow up on what we've provided year after year, so you're only as good as you were last time. It feels that way. So patients' expectations are growing, right? Do you see the same?
I do 100%. And it, like you kind of hinted, it's sort of self inflicted. We work so hard to take those wait times from 3 hours in some instances that I've heard of, down to an hour, down to 30 minutes. And then, yeah, we've gotten so efficient that it's 0 minutes. But then when they come in and we're 10 or 15 minutes behind, they get worried or they get upset, not knowing that one of a few things may have happened. The doctor was a little late. That happens, right? There was an emergency work in, right? I've seen a corneal ulcer, a disaster come in that there's a hole in the cornea and we have to glue it. And so I'm going to be a little behind. Or my practice administrator, no offense, Guido, said, hey, we need to see 5 more patients a day. There's a 3% Medicare cut. We
Mhm.
need to increase the volume. Or you're so popular that you want to increase your volume. I'm not just blaming administrators, but the patients unfortunately don't see this, and frankly they don't care, and nor should they. It's still our
Right.
job to provide excellent care in a prudent manner, in a timely manner. So communicating some of these things are important, and as you mentioned, the quality is so important. I think to us physicians, and to most of us, the outcomes are the most important. We want to do an excellent job in a surgery or whatever it is, but yeah, the patients care about that you listened, that you were on time, and that you heard them. You could have a terrible outcome, but if you listened and said, this is what happened, I'm here with you the whole time, they're very happy because medicine is a practice. Nothing is 100%, nothing is guaranteed. But as long as you're with the patient and informing them and staying with them, you're going to have good outcomes no matter what in helping them through it.
Okay, we talked a lot about challenges, which anyone listening, there's no surprises here. Everyone knows that we have to do our jobs better. It's harder. These are the challenges. So now we're going to talk about how do we go about trying to solve some of these challenges. So, Dr. Jennings, you have all the answers in the world. So just go. Tell us how do we fix our how do we fix our problems? I'm just kidding.
Okay, everybody get out a pad of paper and pen or fire up the Notes app, and we'll tell you how to fix all your problems.
Yeah, and then we'll just be good. Well, I mean, we joke, but there's definitely different ways that we can start to address some of these things, right? There's going to be, automations, technology. To me, and I hinted to this when I introduced you, I think it's also mindset, right? I think we have to kind of reshift mindset of what it's going to take to continue to meet at patient expectations. Um, but I guess where would you start, like in terms of starting to kind of address some of these things?
That's a great question. I'll kind of break it down maybe into two scenarios. The first is a more holistic, which you mentioned. It's sort of a teamwork effort, teamwork mindset. The doctors, at least my generation of doctors, I was trained to work as part of a team. I'm just one part of the giant machine that helps take care of a patient. There's so much that goes on around me that needs to happen for the patient to receive excellent care. They have to have the correct appointment made. They have to be greeted, kindly. They have to be worked up. A technician does, frankly, half of the exam for me. Has to be done, with kindness, with care, and a little bit of thought behind it. I like when my technicians think and order tests and get some tests. I have to make the correct diagnosis and management plan, inform the patient. The billers have to do their job. They have to collect the money. So making sure we work as part of a team and leveraging that, I think, will go a long way. The adversarial components of I'm better, no matter who you are in the whole workflow, if I'm better than you, it's not going to work. And so that's part one, and speaks to your mindset component, which for some may be a challenge. For some, it's going to be very natural. But I'm a big proponent of technology. I think technology is going to be our best friend because it's everywhere. If you follow Microsoft, Apple, Tesla, whatever, technology is everywhere. Medicine has been historically very behind in adapting and adopting new technology because of the fear of change. We like how we like, and we're afraid things are going to mess up our clinics. But there's so much out there that can help us because, especially in ophthalmology, we have a lot of information, we have a lot of data. And from an administration standpoint, from a doctor standpoint, cataract surgery, people are expecting 2020. So, how do we do that? A lot of my colleagues are excellent, skilled surgeons in the lensectomy and placement of the lens. But how do we get that patient to see as well as they want? And that's technology. And so we have to really be just on the cutting edge. Nobody wants to be first, understandably, but you have to be sort of on the edge of finding ways to help us care for patients better and more efficiently. So that's what I'm most excited about.
A quick break brought to you by Boost Patients. If you're listening to this podcast, you're probably a physician, a practice manager, or maybe even a marketing manager of an ophthalmology practice. And you're always looking to grow your practice. You want to bring in new patients. And so you tend to think we need to spend more money on marketing, do more about SEO, website, digital ads, or etc. But we're not so sure. We've mystery shopped dozens and dozens and dozens of practices, and we think there's a major challenge that you have in terms of actually following up with the leads you have. We don't actually believe that you need to spend more money driving new patient leads. We think you need to assess and evaluate how you're actually following up with the leads you're getting and maximizing the marketing spend that you're spending. So if you want to evaluate how your practice is doing this and discuss how you could follow up with your new patient leads more effectively to increase consults and drive up surgery volume, head over to boostpatients.com and book a quick chat with me, and we would love to help you. Thanks, and back to the show.
Yeah, and just to kind of circle back to the bragging about the 10-minute cataract, and not there's a lot that went into getting to that point, right? I mean, you talk about technology, using things like Veracity and advanced surgical planning tools, the advanced diagnostic equipment that we have, our teams of people who are helping surgeons, put data into those models and help try to bring the best outcome possible. The advancements in the laser cataract technology that we bring, the advancements in IOL technology that cost more for a practice. So there's so many things that go into providing those great outcomes that if payers just look at the last part of that journey and say, yeah, we can pay a little less, it doesn't, to me, doesn't make sense. And the only way we're going to get around that problem is, I think, like you said, data driven decision models and technology, so that whole, I guess, thing, that whole journey that we discussed, we can do that more efficiently, and you as a surgeon can help provide those outcomes a little more effectively, and not with hopefully better tools, so that you can, and me as the administrator say, you can do a few more, right, Dr. Jennings, or you can, but it is, and I think I'm glad that you brought those things up, because I think data, in my opinion, is going to help go a long way with solving a lot of these problems.
For sure. And to your cataract example, that's what sort of gets me, especially for some of these procedures that are fairly quick. Flashback to my residency, my first cataract that I ever did, start to finish, took about an hour.
Yeah.
As a resident, as a trainee, you do individual steps. You'll just do one step, and then you show you're pretty good at that. You can do two steps, and then you do three, et cetera, et cetera. And my first solo fly alone with an attending surgeon, just watching in the assistant seat, took me about an hour. I was super slow, making sure everything was good. And then you kind of get, a little more comfortable, and you become more efficient in the surgery. But when you graduate residency and then you enter the workforce as a full surgeon, you're still a little timid because you've only done a few hundred. Okay. This is the most commonly performed procedure in the world, yet you're still a little timid. And you can do now an 8 to 10 minute cataract, not necessarily because you're fast. You discover the efficiencies pretty early on, but you've seen so many ways that you could be blocked, so many potentials for complications, that you make a small little maneuver, a small little change that avoids it completely. There's so many things that can happen that can make a cataract go south fast or have a bad outcome. And it's a really subtle, small change of the hand or setting that avoids that completely. And if surgeons, if you're listening, I hope you're with me, but that's the value, right? The value is not that I can do it in 8 minutes. The value is that
Right.
I did it in 8 minutes all the time and avoided all these potential complications. And things happen, and that goes back to expectation management. If I do 2,000 cases and I had one complication, you're going to remember the one, but that's a phenomenal rate. But patients are expecting perfection because their neighbor had 20/20 vision. So from a surgical standpoint, we still have to work hard as a surgical and medical community to demonstrate value, because it took me a long time to get to where I can do that smoothly and efficiently. But we also have to leverage data from an administrative standpoint. You have to make some decisions. Predictive analytics, what does the patient need ahead of time? Let's prep some things before they even come in. Preoperatively, how can we plan for the best possible care for this patient versus, via an intraocular lens, astigmatism management? Postoperatively, are they able to get to their appointments? Are they doing their eye drops? Do they have other ocular comorbidities? Do they now need to see their retina specialist for an injection? That all takes time, effort, and cost. So using data to help organize that is really, just like surgery, any small change, any small deviation adds up, right? Seconds to minutes to hours to days, and
Yeah.
et cetera, of time saving.
And I would to add to that too, I feel like there's maybe not enough practices that understand all of the different pieces that come together in order to do that. And I'll provide an example just to prove the point, where a couple of years ago we did a project to just try to reinvent our entire cataract process. And when you start to look at start to finish, how do patients find you? What does that message look like? What are the tools that remind them? What are the tools that get them throughout that process? You probably will find different, we all have different software packages that we use for different things like reminders and recall and patient education and all these things. But if you don't really understand how all of those things work as a whole, well, then you may be missing out on opportunities for efficiency, or you might find problems in that pipeline that prevents you from providing that patient that experience that you said that they expect at the end, because you can do everything perfectly, and then one little point in that journey you make a mistake, and that can sour the whole thing. So how important do you think it is for physicians and administrators like myself to kind of really understand all of the different tools, the integrations that we have, everything that goes into that whole journey of providing care to that patient?
It's necessary. It's absolutely required. And as we discussed, I think the doctors get caught up in the day to day and taking care of patients, which that's what we all signed up to do. But we have to be more cognizant of the entire journey. And as an administrator, that's what you live and breathe, right?
Right.
But to compliment you guys, we've known each other about a year and a half or so, and your group does a phenomenal job of constantly looking at your workflows. How can we update this? How can we do better? Because as we've already hinted at in this talk, things are changing. They're not static, right? Doctors go to conferences to learn medical updates. We're learning stuff all the time. We are chronic students, and that's great. It shouldn't get stale. You should always learn new things and innovate, but that spills over into the entire process. Things are changing more and more rapidly, so not only do you have to be aware of it, but you have to take action. Again, your group does a amazing job of leveraging super users. Let's designate some people who really care and who want to look at some of the things, even if it's doing really well. Well, could it be better? Or could we look at 2 years from now? What's changing? How could we do this maybe a little bit differently? Because we see a change in the personnel landscape. That's not even direct patient care necessarily. That's people are working from home, so we're having some turnover. Well, how do we look at this? So that ability to be dynamic and responsive is absolutely critical. If you're not doing that, you're just going to
Mm-hmm.
be set up to fail, because it seems okay now, but things are
Mm-hmm.
going to start to change even more rapidly, and groups may just be left in the dust.
I appreciate that comment. I think maybe the best way that I would encapsulate that is need to try to be more proactive than reactive. And we tend to be very reactive in medicine in a lot of ways. But in terms of, the things that happen on the day to day, a patient's upset. Well, let's go fix it. A patient's, there's this payment issue. This patient didn't have their outcome. So we're very reactive at times. But I think to your point of, can you get a group of people that are thinking ahead, that are thinking ahead of the curve? Hey, we know that these are challenges and we know they're only going to continue to get tougher. How are we going to solve those problems 2 and 3 years down the road? And I think the
Completely.
practice must be thinking proactively. Let's continue down the road of technology. Do you see any other things that are, I guess, coming down the road in terms of technology that may be here today or coming in the future that could help with some of these things?
Oh man, that's a whole other episode. Let's
Yeah.
so summarize. I can mention a few
Well,
things. Yeah, so I can dive in a little bit into EHR and why I sort of went down that route a little bit personally. Interoperability, the ability of things to work together, and then AI we can talk about, because that's sort of a cool thing that a lot of people have heard about, but there's a lot of things coming that will help. In terms of EHR, admittedly, I grew up as a baby doc in the era of paper charts, right? And EHR was first seen as a burden. It was time consuming, it was inefficient. We had to type all these things out versus just draw a little picture and circle a couple codes and be on your merry way. But as we've mentioned, because of all the rules, regulations, compliance, EHR is sort of necessary now, amongst other things like MIPS. But EHRs are now, what you just said, they're being proactive. So it's more than just a vendor or a company looking to get a monthly fee. They actually do want to help, a lot of them at least, and say, well, we want to help you do your job a little bit better. And because of all the moving parts that a practice has to have, as an example, back in the good old days, you could be a doctor with, let's say, what, 3 staff, check in
Mhm.
a person, maybe a technician and a biller, and be just fine. But now you have multiple people in multiple departments. So the EHRs that have these fully integrated solutions are doing really well. The EMR is just the hub, right? It's just the center of the wheel. There's practice management systems, e-prescribing, billing, patient communication, analytics, patient outreach. It's the full suite to help you as administrator do your job, and also, the company I work with, they value themselves as being a partner. You can just pay a vendor to do what they want to do, but I think my role is unique in that I'm a practicing physician that also works in EHR, trying to give my feedback to how it can be better. We all have the same pain points. So why not use our clinical knowledge and work together with groups like ManEye and others to say, well, we all have this burden. Let's work on this together because it's not going anywhere. So even though EHRs and doctors still say this takes me forever, I could see patients faster with paper. Well, that's true. I don't think EMR documentation will necessarily ever be faster, but it's going to be more complete. It's going to be more compliant. We can read the handwriting. Communication between doctors is only going to become better. So there's still a lot of advantages, and you just can't use paper anymore. So we have to kind of get over that hump and leverage what we have to move forward.
And you described it, and you mentioned the word AI in what you said, which is, it's in every sentence, to every conversation. It feels like, and every vendor is racing to do some flavor of AI, and specifically, with ModMed, and I know you're working with them to help develop tools to help physicians and practices document more efficiently. I think that we're really excited about the scribe component, and I know other vendors are working on the same thing, and I know you've been working on it personally. Do you think that AI scribe is going to make a significant difference in the lives of physicians? Because I hear some skeptics, the physicians are like, I got my scribe. Like, how is it going to really help them? I mean, has it made a difference for you? And do you think it's going to help in the future?
I do think it's going to help. Just holistically, one of the biggest burdens and causes of burnout amongst doctors is charting. And this goes back to the EMR versus paper, right? Even with paper, back in the day, docs would still have a ton of charting to do in the paper chart, writing paper prescriptions, calling patients back and documenting it. It's just different now. There's still tons of clicks, things to do, things to document. Doctors are charting their notes into the wee hours of the night. Fortunately for ophthalmology, it's not as common as our colleagues in primary care because of the tremendous amount of data and communication they have to have. But a lot of the documentation, let's be honest, it's redundant and it may not be really pertinent to patient care, but we have to do it. We can argue all day, but we have to do this documentation. So EMR is something we have to do, and taking the notes is something we have to do. Leveraging AI as a dictation mechanism is going to help a ton. To your point, what you mentioned, a lot of doctors have scribes, especially ophthalmologists, because of our patient volume. The docs have scribes. They love their scribes. I've heard a lot of my colleagues, their scribe essentially runs their life. They can tell them who to see, when to use the restroom, when they can take lunch, if they can take lunch. I don't see, for those docs, I don't actually see AI replacing that scribe. I think because of the volume of things that need to be done, that scribe will now be free to do other things. I've seen a successful model where the scribe doesn't do as much of the note taking as much as clinic management, clinic flow management. They can move people, they can get a test, they can go grab some jeweler forceps, some eye drop samples. So that scribe, or whatever you want to label them as, can still help the physician and quote unquote run their lives, their clinical lives, but AI can still be listening and still take the notes. The AI solutions we're working on will do more than that. It can help e-prescribe. It can do orders. It can send a follow-up to the practice management system. But let's be honest, AI does not take vacation. It does not go off to medical school. It does not call out sick. So again, for docs who love their scribes, I still think there's a really good use case for it. And for those who have, let's say, 3 scribes, maybe now you only need 1. And you could repurpose people. We're all about good people. So with the need for great people in an organization, let's find something for you to do to continue to help our business. But I think the AI scribe is going to make the biggest dent because of physician burnout regarding documentation. But there's a ton more that AI is going to be able to do because of the ability for it to do repetitive tasks.
And you mentioned the scribes that run the physician's life, which I see that all the time. So maybe it'll make that conversation, because with those scribes, a little easier for the physician, because sometimes I'll hear them, they're even afraid to give them real feedback, like, hey, you missed that part of the note. So maybe the AI scribe will actually help, because it's going to help that scribe with their documentation, because it's straight from the doctor's mouth, and it wasn't something that the scribe that they love, that they're scared to say anything to, that missed in the documentation piece, right? So I think it's going to probably help that relationship with the physician and their scribe, not replace it. So hopefully we can get that message out there.
Completely. And I think I'm a little jealous. I know some doctors have that one or two scribes that they absolutely love, that they entrust with their lives, but not everybody does. The scribe can sometimes be a high turnover role. It's college students, it's pre-med, it's pre-nursing, it's pre-optometry, whatever it is, it's sort of transient. And as you know very well, the cost and time to train somebody new is fairly high, especially when you're dealing with a doctor who is very particular about how they like to do things, how they like to document. This is a way for almost anybody in a scribe role can come in, and the AI will do a lot of it for them. So the actual documentation is a whole lot less. Further, not to go too much into ModMed, but the solution that we have has a checkpoint, right? It's not just going to convert everything to text. There's something called a reconciliation, where it will ask you, hey, this is what I heard, and this is what I'm going to do for you. Is this cool? And so that's where the scribe can come in handy to change, edit, modify, or accept all of those things. And you know what? That can be done while walking the patient to the front, or walking them somewhere else, or doing other tasks while the physician's already moved on to the next room and started recording in the next visit. So for those docs that are afraid of what AI can do, there is a nice little checkpoint to make sure everything's okay. And the educational piece of that will be a lower overhead, a lower burden for training new people, if that's what you need to do.
So I guess the pearl here would be, don't resist it. Like, dive in, right? If you're a physician.
Investigate, right? We're not here to tell people this is what you have to do, but I think that's a great point. Don't be scared of it. At least give it a try, see how it could integrate into your workflow. If the scribe part of it isn't particularly helpful, then don't use it. So many other AI tools are coming, for example, and this is not unique to any EMR per se, but the ability to have AI move around your documents, classify your documents, do tasking, the ability for AI to automatically detect a claim is going to be denied before it's sent out. All of these things, to our original point of helping the day-to-day burdens become slightly easier, are going to be tremendously helpful. But don't just be afraid of AI. Just, if you're afraid of it, dabble into it. Again, maybe the scribe's like, oh, I see how this could be used. I won't use this all the time, but for new patients, it might be helpful. Just, investigate and see how it could be helpful, because ultimately, I believe this is tip of the iceberg stuff. Because medicine is usually so behind, the fact that we're just implementing these things means there's a whole lot more on the horizon.
And I did another podcast with someone else, and I think he said it the right way, is that if you're hesitant and you're afraid for whatever reason, or just don't have the knowledge tools to do it, make sure you select the right vendor to work with, who you trust with your patient data, and that you can trust to approach the ethics and the security in a way that you would do it yourself, right? And one last thing on this topic, and I'm going to make a bold prediction, and now I've got you in recording, so I'm going to see if I can hold you to going back and bringing this message back. But in our practice, the scribes tend to be the most tenured, the most experienced, the ones that the doctors trust the most to help them charge. So there's slightly lower turnover in the scribe role, but the workup technician role tends to be higher turnover, just because it's the nature of the experience. But I think that AI ambient listening is initially, especially I think in our practice, is going to bring more value to the technician conversation, because I hear it almost every day. This technician missed this. They didn't chief complaint appropriately. Whatever that concern is about the documentation of that technician. But so then, because And the reason I say this again too, because one of my physicians said that when I said, "Hey, we're AI scribe is coming," he's like, "Yeah, that's great, but when are we going to get AI tech?" Because that's where they're missing it. Because if they can call out a refraction that they just did, or if they can call out the chief complaint, and then the compilation of that information comes in much faster, then the data is better, and hopefully from the practice administrator side, that it's faster, so that we can either do more exams or we can do more with less people. So I'm going to ask you to commit to take that back to the team and say, hey, we need to really focus on AI tech, the technician side, because I think it's going to be huge.
Yeah, I mean, you're 100% correct in thinking about efficiencies. The technician workup is a huge bottleneck. And I have wonderful technicians, but still, it goes back to charting. They still, in any EMR, they have to record this information while talking to the patient because I can be in and out with a protocol pretty quickly. That was a big consideration of mine in my role where the scribe part of it for physicians took a priority because of the potential for uh, helping with burnout and because of the implications of billing and coding and capturing the relevant clinical information. However, I have already um, emphasized the need for AI ambient listening to function from the technician workup. So I can't talk too much more about it. If you're interested, come join ModMed. We can talk more. But absolutely, that's already been discussed internally because I absolutely have recognized the value there. So that's a promise for sure
All
because
right,
I
it's
totally agree
recorded.
with that. It's recorded. I'll go on record. I totally, because again, value here is I still practice. I'm in the trenches, and I see a huge value add for having a technician just talking to the patient, calling out the uncorrected visual acuity, calling out the manifest refraction. The IOP was 12 in both eyes, obtained via Eyecare, and never touched the screen um, except to confirm things. That would be a huge time save in the patient workup journey. Even though it's a high turnover role, um, you still have to teach them how to tech, but the again barrier to entry to utilizing a new EMR and time spent uh, would be pretty huge.
And again, I'm going to go back to speed because historically, our fastest technicians were the ones that could do the entire workup and not turn to the computer. They would do the workup, they're remembering, they turn in the computer, they boom, 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 enter it in. But that's not the most common. Most common is that the technician will, get the visual acuity, turn around, click, 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 put in the acuity, start asking questions about why are you here, type, and then so on and so forth. I don't have to go into that further, but you understand where I'm coming from. So I think we've made the point. So hopefully we can go down that path because I think it's going to be very, very useful for practices. So are there any other insights that physicians or administrators, anyone listening, should consider as we go through this journey of automation and using technology to address some of the challenges that we've discussed?
Yeah, just a couple overarching things, right? I'm excited about AI, I'm excited about technology, but we do have to be careful, right? You kind of hinted earlier about ethical concerns. I'm passionate about things like data ownership. That's going to become more of a forefront as this becomes more popular. We had to kind of get consent to record the audio to utilize AI. But when we're using patients' data to train AI models, to use cataract surgery planning tools, patients are going to get wind of this. And frankly, they should and say, well, am I okay with you using my data, even if it's de-identified? Privacy, where is that information stored? Is it de-identified? How are you using it? And with the AI twist is model bias. AI is really only as good as how it's trained, right? And it's very easy to believe an output. If somebody shows you an AI tool, you go, oh, that's cool, it's AI. If you type in a question, let's say ChatGPT, and it gives you an answer, are you going to believe it? As medical professionals, we're trained to read, vet, and frankly, tear apart medical studies to make sure it's not biased. But we have to have the same criticism for AI. There's already reports of AI bias depending on how that AI model was trained. There's such thing as AI model hallucination, right? If you want to Google that, it's pretty fascinating. So we have to be careful because it's a very powerful tool. But just like everything else, it's not going to just replace us. I know docs are nervous about that, but we have to be careful how it's used and what respect. And, to wrap it up or take it all the way back, that things are just changing. Things are changing rapidly. It's going to take a team effort, administrators, techs, everybody. There's a lot of regulation, a lot of new technology. So don't be afraid of it. I would challenge any doctor listening, get involved. Don't be so high in your horse that everybody has to do everything for you. As kind as you are to say, I don't have a scribe, a lot of docs can function without a scribe initially, especially if you're at a new group or you're low volume to start. Make sure you know how to use the darn system, whatever it is. Make sure you know how everything works so you have a basic understanding. And then if you're getting so busy that some of the things are out of the realm of possibility, that's when you leverage help. That's when you have more than one technician. That's when you have a scribe. But make sure you understand how it works, because that way if your technician's out or if your scribe is out, how it works. Versus I've seen some scenarios, although it's been a while, where someone couldn't even log into the site because they'd never had to touch it before. As a doc, you're still responsible for the whole patient. You don't have to be an expert at everything, but understand. So as we get into the technology, ask questions, look at use cases for different things, and make sure you're working as part of a team.
And thank you for helping that point that I made earlier. I like to give my physicians a hard time, but realistically, the scribes that they use and the way they do it, it's amazing, and they provide great care. But I like just to use a Dr. Jennings rules just to get a little perspective. Just a little dose of perspective never hurt anybody. Well, Dr. Jennings, always a pleasure to catch up with you. I really enjoy your perspectives and your approach to trying to give patients better outcomes, better experiences. And I also appreciate your passion for doing those things and being involved with different groups in order to achieve those goals. So appreciate your help in what you do for ophthalmology and just also for us as a practice. And I appreciate the relationship. So thanks again for joining us.
Thanks so much. Very kind of you to say, and right back at you. You run such a wonderful group. I use you guys as an example as well for how to run such a big practice, but make it seem small, and attention to patient care and staying ahead of the curve and being proactive. I've learned so much from you in the time that we've known each other. So thank you for all of your insights, and thanks for the invitation to do this with you today. It's always great catching up.
Awesome. I'm going to take that snip you just said, and I'm going to send it to Dr. Mann.
Time for a raise.
Okay. And thanks again to the people listening. And if you want to keep up with the ophthalmology experience and the interesting conversations that we have with our guests, please don't forget to subscribe, and please share us with your friends on social media, where we're just getting started out. So it'd be great if you can share. And another shout out to Boost Patients for producing the podcast. Boost helps ophthalmology practices get more from their patient pipelines without spending a dime on marketing. You can learn more at boostpatients.com or check out the show notes. Hang in there, ophthalmology gurus. I know it's tough, but we'll get through this together, and have a great week. Thanks.